So, as Alga told, I am working with Ari implants for almost 4 years right now. So I was the lucky one to get them very, very early. So that's why I have some experience now and I can present to you my cases. So today I will try to show you the possibilities, uh, what we have with the newest products on the market. And as Alga told, if you have any questions, please write it down. Or if you have an urgent question, you may really interrupt during the webinar. It will be easier to answer during the slide that is on. So basically, to start with, guys, I want to start with the case. Just look at the case, look at the situation in the mouth, and try to imagine that you're back to your office tomorrow, Monday, whatever, and an important patient is coming to you. A patient who is your relative, who knows you, who you know, and she has a fistula around an incisor, and it's obvious that the tooth needs extraction. So what you're doing, your plan is to do a OPG, CBCT, or whatever you're doing in your clinic. And here from this case, from the OPG, you already see that the central incisor has a really big infection and we cannot treat it other way. So basically what we have to do, we're extracting the tooth. And after extraction, what do we see? So we open the flap and we see big, big hole, huge infection of the alveolar part of the bone. And what are our options here? So imagine it's your everyday, next day, let's say next day patient. So what's your options here? How do you go to this case? How do you treat this kind of patients? So usually what I was doing, and I believe most of us are doing right now, so we're in the discussion of bone augmentation techniques. So we're choosing the bone blocks or GBRs. These kind of defects cannot be solved otherwise. That means what? That means that we are placing an implant and doing a final loading, let's say in around a year, because we need our bone to heal, we need our implant to osseointegrate, and only then we can do the final loading on that kind of defects. But guys, is it really what our patient needs? Does our patient come to the clinic for a bone augmentation? Do they really want and do they really seek a final tooth in a year? I think that's not the main thing what the patient are looking for. And of course, for us as clinicians, where do we get the most complications? Going to the literature and then reviewing my own cases, and I believe from your uh, personal experience also would be this very similar numbers. The biggest amount of complications comes where they come from bone augmentation, because it's much more difficult and complicated to do a difficult massive bone augmentation than just to simple place a dental implant. So we might lose the bone particles, we might lose the block, we, we might have the opening of membranes. So lots of complications coming and we have to deal with it. But what if there was an easier way? What if we could avoid doing all this kind of steps? So from the station where we had a solution in a year, we're offering you to jump it to a 1-day solution. Do you think it's possible? So basically, just by choosing a different dental implant, we might save 1 year of procedures. And now I'll try to show you what I'm talking about and how does it look in real life. So basically, that's the same patient where you saw the huge defect. She's after surgery that took 30 minutes. It's already with healing abutment. and we're fabricating chair side, the provisional crowns, and doing a final temporary loading same day of the surgery. So from the defect where he had huge uh, bony wall defect, 3 walls defect, she left the clinic with a temporary crown. And this is how it looks in the OPG. So that's kind of different implant what we're used to. So as you see, the implant in the central incisor I placed is very long. This implant is a little bit different. It's made of 2 pieces, let's say like that. So the first one is our well-known Enrich implant. That is the body of the implant, and this is the threaded part of the implant that goes and gets primary stability from basal part of the bone. So we're not looking anymore to the defect that is in the alveolar part of the jaw, but we're getting primary stability, osseointegration from basal part of the jaw. So this part, the threaded part of the implant, is the zone of osseointegration, and the blue part, where we have the cuff of implant, that is in our defect, that's the zone of contourization. What does that mean? That means that we had to contour the soft tissue around the implant cuff. That's it. We do not need to augment bone there. We do not need to do any difficult bone augmentation procedures. We just do simple bone contouring. I will try to show how I do it. So the implant, again, has 2 zones. This zone where it gets osseointegration and the zone where we contour the soft tissue. So this is the final CBCT and final view of the patient with temporary crown, same day of the surgery. 3 months post-op, very stable bone. We do not lose any bone apical mesial. And that's the most important picture. We remove the crown, and what do we see? We see healthy tissues. So healthy soft tissue in the situation we had previous. So we had a huge defect. We didn't do any bone augmentation. We loaded the implant immediately, and we have this kind of soft tissue after 3 months. In my opinion, a really good result. Buccal view. And most important, everyone asks, how does it look in time? So 1.5 year follow-up. From the X-ray, we have stable bone everywhere around the implant. But the most important, again, for us as clinicians, is the intraoral view. So what do we see? We see healthy tissues around the implant. And looking at other teeth that the patient has. And in my private practice, most of the patients are like that. They walk until the last. So a very minimal amount of patient comes to you, then they see a minor problem. So most of them comes in situations like that. So if we can get the final result in healthy tissues like that, and after a 30-minute surgery, so why shouldn't we do that? And of course, it is not still science-based. We do not have a lot of papers around this kind of products, but we're working on that. And this was one of the first articles published. But soon more and more are coming. So as I always say, this is not a clinical upgrade for us. This is a patient experience upgrade, because what does the patient feel? He feels easy, safe, and fast surgery. This is everything done for the patient. And for us as a clinic owners, it is very important, because in the country where I live, we have a very big competition of the market. So we have to be a little bit different. We have to offer something different. And in my personal opinion and how I try to work is I always try to load my implants. I always try to go immediate, because I think if the patient is leaving without a tooth, he is more likely not to come the next visit than the one who is leaving with a tooth. So basically, again, it's not a clinical upgrade for us, it's more the upgrade for the patient. And imagine you being a patient yourself. But what are the patients afraid of? Most of the patients. They're not afraid of titanium. They're not afraid of bone augmentation materials or nothing. Most of the patients, they're afraid of being without tooth. That's why they wait so long. That's why they don't come to the clinic faster. So this is a way how we can solve this patient's problems. And of course, for us as clinicians, every patient has anatomical issues where we have limitations and we cannot place a standard implant. So bony defects, nerves, width insufficient, lesions, sinuses. So we have lots of anatomical considerations to think about. But looking to the case, we can choose from a big variety of solutions possible. So having in mind all these limitations, what modern solution can we use? Think about that. We're living in 21st century. So we have to make it fast, simple, painless. This is what our patients are seeking for. So again, look at the video on the screen. So basically, we're extracting a tooth, and I was taught a long time ago to work using only OPG. No one was doing 15 years ago CBCT. So basically, imagine any clinic, you do not do CBCT, or you do CBCT, but really, how often can you measure the thickness of the buccal wall prior extraction? It's really hard, and I believe no one is doing it. So it's a casual case. We're removing a central, and we promise the patient that she will leave the office with the tooth. But after removal, we see that we do not have any buccal plate. So what I was doing before, I was augmenting the bone and waiting. But now there's a modern solution and makes my life easy. So that was my OPG prior the surgery. I'm extracting the tooth and open the flap, and what I see? I see that I have a defect of buccal plate for about 6 millimeters. That means that I cannot place a standard dental implant if I want to have a good aesthetics. But here, Ari comes, an origin incisor implant. It's a saver for us in the situations like that. So as you can see, even we are having a defect of, and we do not have a buccal wall, we're placing a big implant, 4.5 in this situation, an origin incisor. But the thing is that this implant is getting primary stability in other part of the bone. So we're not using alveolar part of the bone anymore. We're using the basal part of the bone. So our implant is going deep to the base of the maxilla. We're getting good primary stability, and we're leaving the cuff open. So this cuff, as you can see, is leaving exposed like that. And from this video, from this photo, you can see how good the primary stability is. Even in the defect like that, we're getting 45 Newton centimeters of primary stability. That means we're safe to load the implant immediately. And this is how the patient lives. Immediate implant, immediate temporarization. This is the CBCT post surgery, and you can see that the threaded part of the implant is fully in the bone, in the basal part of the bone, and the cuff is left exposed. 1 year later, the patient is coming back. We see stable bone, and the most important picture for me. Look at the soft tissue again. The tissue are healthy, stable, looks really good. The patient is super happy. 1 year later, again, removing the crown, look how good the tissue is looking. So we have healthy, stable, soft tissue. And she's coming 3 years later. look at the photo. Everything is stable. Everything looks good. But now look at the next picture. So she got the second Ari implant after 1.5 years from the first one. So basically, around both implants, we're having great soft tissue, and we didn't do any bone augmentation here in this case. So this is the possibility that we have by choosing the correct product for correct clinical situation. So guys, going to the literature and going to your cases, think, are all immediates that you do stable for a long time? Isn't it sometimes that you do extraction, you do curettage, and you check that you have the buccal wall is all intact, you have no problems. You do an immediate implant, you do bone augmentation, you do loading, everything looks good. But somehow in a few weeks, you lose the implant. This is because the buccal plate is sometimes it's very thin, and we cannot measure how thin it is only from CBCT. It's very difficult. So if the buccal plate is thin, we tend to lose it. That's why we lose our implant if it is placed in the alveolar part of the jaw. And another review, they all say the same, that after implant placement, we tend to lose bone, even if we do bone augmentation. So guys, here comes, sorry. Here comes the implants I'm talking about. The new products that are now launched in the market, and especially today we're talking about Ari, but Blue Diamond Cuff has the same philosophy. It's just designed for posteriors. So basically, in Ari, you see the same any-ridge body implant. The threaded part of the implant is the same any-ridge implant. On top of that, you see the red arrow shows the cuff of the implant. The cuff is machined. It's not polished. Very important, because lots of people think then see it, that's a tissue level implant, and they think that it is a polished neck, but it is not. It's a machine cuff, and the blue arrow, it's the groove zone, or this is formed 17 microns grooved zone formed for our soft tissue attachment. So this is how the new implants are looking. And the most important classification is here from Khan. So try to look at the bone, and the bone changes in time if we do not do immediate, or even if we do. Guys, so if we're not doing immediate, how does the bone change in time? So in all classes, we have bone resorption, all the alveolar part of the bone, but only one part, the green part, is not changing in time in any class. So basically, that's the basal part of the bone. So if we have the bone that does not change in time and has good vascularity, is infection-free, why shouldn't we use it? So this is the idea of Ari implant. And if we're not using that, and we have defects like shown here, try to think for yourself and imagine how long in any of these cases, in any of these classes, we would need to wait for the final loading of the implant. So basically, it is from 9 months to almost 2 years. So again, we're living in 21st century where everyone is seeking for fast, painless surgeries. So if we have an option, we have to try and do it. So what is Ari? What is any-ridge incisor? And what is the key features? So the main feature is that it is designed for thin ridges. It has an ultra narrow cuff, and it is has a very good primary stability with its threaded part of the implant. It has reduced stress on the buccal plate because it has no threads there. It's only machined cuff. And as you saw from the last few clinical photos, it has a really good soft tissue adaptation. So we have really good aesthetics around this kind of implants. So basically, it eliminates bone grafts. It is targeting. It is basically made for immediate loading, immediate placement. It is very strong, and of course, the range of prosthetic components is very, very wide. But what is most important? The most important thing here that is super easy workflow. That means that you don't have to be very skilled surgeon to do a difficult bone augmentation. You just can place an implant easily, and you don't need any additional surgeries with that. What is about periimplantitis? What we're afraid for, and what is a periimplantitis? Try to define that. The periimplantitis happens when we tend to lose bone about our implants. So when we lose the first millimeters of the bone, infection comes there, and then the periimplantitis starts. So guys, what's happening to our implants, standard implants, then we lose bone and periimplantitis starts? We have to clean it. So most of the time, what we're doing, we're brushing the implant and making from rough surface machined. In this scenario, we already have the machine surface. So in case any bacteria is there, it is very easy for us to clean because the surface is not rough, it's machined. And the cell-like groove zone is designed for the collagen fibers to attach, and our soft tissue is like glued there. So that means we do not have pocket formation. And if we do have some bacteria around that, we have in the first 2 millimeters that does not go deep inside. Why it is important? It is very important because the implant integrates way, way, way above that. So our implant is integrating in the basal part of the bone, and the cell-like groove zone where the soft tissue attachment is formed is at least 4 millimeters above the osseointegrated part of the implant. That means the part where the implant is integrated in the bone is basically infection-free. And another very important, and in my opinion, one of the most important features of Ari implant is that it is a conical external hex connection. Having an external hex lets us have very stable prosthetics. We do not have any micro movements, and it makes the implant even longer. So what's the difference from the normal hex, external hex? So usually the normal external hex is much shorter. It's only 0.7 millimeters. And in Ari case, we're having 1.65. So it's double the height. It's much longer. And very important thing that this hex is conical. So it's not straight. So basically, we have very good retention with our prosthetic components. So guys, anterior defect is for Ari implant. If we're having an anterior defect, we do not have a buccal wall, but we always have what? If you remember Kahn's classification that I showed, we're always having the basal part of the bone that is good for us, and we can always use it. So we can target that part, we can place the implant deeper and get our primary stability from there. So this is how the implant looks inside the mouth. It's already placed 2 implants. And with the defect like that, we're able to load with temporaries same day. The machine cuff has also a machine cuff, and the cell-like groove zone is the most important part of the implant, as it forms the soft tissue attachment. So on the machine cuff, on the zone where the grooves are, the cells are just sticking as glued. So already in year 2000, people were investigating the surfaces of the implants. They are trying to find what kind of surface is the best for implants. So if the implant is too smooth, and the surface, sorry, is too smooth, the cells just don't get where to go. They just randomly spread. If the implant is too rough, the cells has nowhere also to attach. So the surface has to be specific roughness for our cells to attach. So this grooving of the implant, we're not deciding those grooves for mechanics. We're just deciding topography for biology. And this is how it looks under the microscope. Look how the cells are migrating and moving. So basically, all these grooves are just literally telling the cells where to go. It's like railroad. The train on the road, it doesn't go anywhere else. If you look at the picture on the right, so where the cell has the road, it goes straight. If it loses the road, it just randomly goes anywhere. So basically, this is what we're doing to the grooving part of the implant. One more picture under microscope. Just look how the cell goes straight on the road. This is our groovy part of the implant. Other part of the implant, very important, is the knife thread. The knife thread is the crucial for what? It is crucial for primary stability. It is very important and one of the key features of any ridge implant. What is most important? That is one single continuous knife thread, which goes through the whole implant. And it really, from all the studies, it outperforms lots of different systems in primary stability. And just look how smooth it goes in the bone. The ones who are using AnyRidge already know it, but really the one continuous thread, it does not harm the bone. Just very simple, smooth, easy entrance into the bone. That is very important feature of Ari also. And the last thing in the theoretical part is what is? This is surface. xpeed surface is for osseointegration. And now it is a very, very big topic worldwide. xpeed surface is, from all the studies right now, is the best surface also integration wise. So that means that we only need 6 weeks for final loading. Our implant is also integrated. And in this case, Ari has xpeed both on the threaded part and on the cuff also. So both threaded part and machine cuff is xpeed surface. And from the literature again, we have lots of data that really xpeed outperforms all the other surfaces. And even if we want to do it even faster, nowadays we have a plasma X machine that can enhance the osseointegration, that can make our implant surface active. So according to the science, with the plasma X activated implant, we have a bone to implant contact almost twice as big as the non-active xpeed. That means the osseointegration is much, much faster with the xpeed active. And this, we do not, as I mentioned before, we do not have data so far about the soft tissue reaction on the Ari, about anything. We're just working on that. But from a long time ago, we have many articles on the similar implants, the machine surfaces, and how the soft tissue reacts. And all of them say the same. The tissue reaction to machine surface is very stable, good, and healthy. One more case. So this is why we're here. So guys, the patient is coming. We have a huge infection, And prior to coming to me, the patient visited 10 other clinics. He wanted an immediate smile, but all of the doctors refused. And from the picture, you can see why. He has pus, he has a huge pocket, uh, probing everywhere, the pus is coming out from everywhere, the tooth is mobile. That's obvious, we have to remove it. And as I told you, and all the brochures say that we do not need to GBR, do GBR with ARIA, but is it always like that? So here comes, in my opinion, the most important slide of, let's say, today's webinar. If we have soft tissue and our soft tissue is thick, we can leave the cuff exposed and do nothing. But if our soft tissue is thin, we have to do something. As I told you in the beginning, there's a contourization zone. So we have to contour our soft tissue around the color of the implant. So it's either connective tissue graft or bone substacles plus a membrane. It's up to you which to use. So the previous case, I'm doing extraction. I'm placing an implant immediately deep inside the basal part of the bone. The cuff is exposed here, but my soft tissue thickness is not enough. So what I'm doing bone contouring. I'm placing bone substitutes here that is slowly resorbing. My goal here is not to augment bone. My goal is that the membrane, then the material stays here for a long time and it contours my soft tissue. So I'm putting the material, I'm putting the membrane to thicken my soft tissue, suturing, and I'm taking an impression. As it was one of the first cases, we didn't do it chairside, we did it with an impression. So impression, 1 week post-uploading, and 3 months later. 3 months later, what we have stable, healthy, soft tissues. So that is what the patient is coming to you. It's coming for his smile. And of course, it could be better. We could achieve a bit better result if we do delayed, staged with GBRs, bone blocks, or whatever we're used to. But is that 1 millimeter that the patient really needs? Most of the times, they come for that. They come just for the smile. So before and after 1 year, look how good the bone is remodeling and how good the reaction of the bone is around that kind of implant. So basically, here's all the possible scenarios of Ari implant. We are having 3 lengths of threaded part that goes in the basal bone, 5, 7, and 9. And the cuff can be 4, 6, 8, and 10. So we have a big variety where to choose from. Again, indications, single anterior tooth replacement, laterals, narrow ridges. Of course, a big topic again, the fractures. And Ari was compared to any other mini implant in the market. For now, it's much stronger of any of those. So we're safe if we use it in correct position. So that is why we have to use it only in anteriors, because it has a very narrow cuff, only 3.2 in diameter. And of course, if we place the implant that deep, what do we need? We need an intermediate abutment. So here comes the new AXA to save us. Why do we need an intermediate abutment? This is obvious that we have to be passive and we have to avoid the micro movements. So in order to achieve that, we have to use any type of intermediate, octa, MUA, or AXA in this case. So what I was trying to show you the last 30 minutes is that we are not using the alveolar part of the bone anymore. We're using the basal part of the bone, and we're placing our implants and getting the primary stability way, way deeper when we used to. That means that most of the implants are not in the best prosthetic position. That's why we need an intermediate abutment. So it's stationed like that, big defect, we're placing an implant, you see it's exposed buccally, we're doing just contourization of soft tissue, and we're loading it finally straight to the implant. Look where the screw holes are. The patient is super happy because she's old and this is what she came for, but in the mouth it looks terrible. For us as advantists, it's a nightmare. It's not the best job done. But look at the X-ray, looks good, and 12 weeks post-op, the soft tissue reaction again, very, very good and stable. So this is what, again, one was on the first my cases. So I didn't have AXA at the time of surgery. So I had to do this kind of prosthetic. And later, after 4 months, I'm redoing it. I'm placing AXA abutments on Ari implants and multi-unit and Octa in the side, just for you to see the difference. See and check how all the abutments look. And the most important and obvious difference of AXA is the post height. AXA is twice as high as an MUA. That lets us do metal 3 restorations. And here comes the zirconia on top. Already the screws are in correct positions, and the patient is super happy. She was super happy with the previous temporary, but now even more. So 6 months post-op, very stable bone. We do not have no resorption, nothing. And here we have the biggest differences of all of them. As you can see, the difference is in the screw. So AXA has bigger screw, and the fracture of the screw comes after a much higher torque than MUA used to. And my take-home message, guys, today is, I know that it looks skeptical. I know that it looks different. I know that you might have and you have to have lots of questions because we're not used to that. But everywhere in the world, we're involving. So it's an AI time right now. So think about that. Think that 10 years ago, then a simple immediate case looked like a dangerous one. And no one was doing immediate. Everyone was talking delayed, immediate won't work. But look what's happening now in the world. Everyone is doing immediate. It's a routine practice. And even more, 20 years ago, then Paulo Mahler introduced an all-on-4. Everyone thought that it's insane. Only 4 implants for a full arch. But now it's a routine procedure in any clinic. So again, we have to think different. We have to go out of comfort zone. We have to think from our patient's perspective. We have to think not about ourselves, not about what we're used to and what we're good at, but we have to think a little bit different. What are our patients seeking for? Is there anything in the market that can help me to help my patient to get the result much faster? And if there is, why should we use it? And as everywhere in the world, there are invaders, the guys who start the first ones, who just jump in, start working, the early adapters that adapt later, and then the late adapters. So I suggest you to go out of your comfort zone, challenge yourself, pick a case and try. If you have any questions, you can contact Megagen UK or directly me. I am more than welcome to answer and help with your first cases. So thank you for being here tonight and hope it was interesting.
All right, well, I'll jump in then.
Okay,
Thank you,
so
Rokas.
I stopped sharing my screen. You can.
Thank you very much for that. Very good presentation. Of having some comments coming through as well. So yeah, great, fantastic results. So Rokas is, as he said, he's been using it for the last 4 years. Very experienced. He had access to the stock as soon as it was available. Unfortunately, my experience is a bit more limited because we've only just had it in the UK very recently, and yeah, I mean, I guess I'm here just to show you and share with you my experience with Ari as well, and just to share a case if my screen loads up properly. So it is really a game changer. You know, Megagen they do really think outside the box. I mean, a lot of their products are very, very innovative, and nothing to do with the innovative implant training. I'll come on to that later, but they do really come up with innovative products. A lot of the stuff they do is they take existing ideas and just make them a lot better. Basal implants are not new, but they had a bad rep for many, many reasons, and they've taken the best part of it and just made it made it workable. And we can use them with screw retained restorations and with multi-units and AXA and other things. So so I'll kick off. As I say, I'm going to sort of not dwell on things too much because obviously Rokas has already said it. But essentially, we're here to talk about this amazing implant, and the Ari implant, which was designed for the anterior region, for the anterior atrophic ridge, and was then the sort of the machined part and the magic cuff, the cell-like grooves that they have, that was then taken and added onto a blue diamond to produce the blue diamond cuff. Essentially the same kind of thing, but where we can then use wider implants, have an internal connection because it's not as narrow, and the ridges aren't as narrow. So it was that good. It was added onto blue diamond. The great thing about blue diamond cuff is that it's the same platform as blue diamond. So in terms of the connection of the scan bodies, heating abutments, everything else, it just makes stock a bit easier. Obviously with Ari, it's a little bit different because it's an external hex design. And just to briefly touch on the things that, as I say, Rokas has already mentioned, it was taken from the Any Ridge, and it's Any Ridge incisor. It's got the knife thread design, which gives us that primary stability that a lot of us already use Any Ridge and really love. And you can't really find that with any other implant brand, getting primary stability almost every time when you need it. As I say, it's used for the anterior atrophic ridge, and we're getting very good stability with it in severe bone loss situations as well. Using the basal bone, so we're getting the anchorage from the basal bone and having the machined neck to house our restoration where it needs to be, at the sort of gingival margin kind of level, as it were. And then we're getting the soft tissue support, as was mentioned before, keeping the bacteria away from the roughened part of the implant, protecting it with cell-like grooves, keeping the fibroblast attachments there, preventing any bacteria from slipping through. And as it was mentioned before, the external hex, which is a very, very good external hex as well, much longer. It's got a 10-degree taper, so you're trying to get some kind of reverse conical connection, you could say, and get some stability from our restoration. But even if you do get micro movements, our roughened part of our implant is so far away, it doesn't really have that impact that it would with a traditional external hex. Right, so I'm just going to share a case with you guys today. It's a full arch case. This is Maria. She came to see me a couple of months ago. So it's a fresh case, just completed recently. She had only 3 upper teeth. Okay, the lowers are needing a lot of work, of course. Oral hygiene isn't ideal, and actually we're looking to do a similar thing in the lowers with a full arch implant treatment. But due to finances, etc., we just focused on the uppers. Only those 3 upper left teeth present. And when I first took a look at her, did the photos, looked at the did the intraoral examination, thick soft tissues, looks like a nice thick ridge. You think, it's a nice straightforward case. Put 6 implants in and get it loaded. But it wasn't quite the case when I saw the CT scan. Very, very thin ridges, where there weren't any teeth, where she's been wearing this denture for many, many years, typical kind of scenario. So I planned here, this is on the software, using a 4x10 Any Ridge, just to have an idea. I think the one on the right of the screen is a bit longer. But just to kind of have an idea of where we are with the bone, and that is the basal bone, where I've placed those kind of implants. So one option was, well, just, bone leveling, right? You just bone level everything, and you have this huge, huge prosthetic, and lots of plastic in her mouth, which will later be zirconia. But these are the only 3 areas where the 3 implants that needed Ari. These are the only three positions. Actually, where she had teeth, we didn't need to remove so much. And then how much are we going to remove? We're going to enter the sinuses as well, right? So you do bone leveling, you're getting much closer to your anatomical structures. So not an ideal situation. What's an alternative to this? Rebuilding the bone. Yes. How long is that going to take? How are we going to temporize her? Obviously not with the denture. There's all these other things you've got to think about. Zygomatic implants, potentially. But why go to something so invasive when we have these products? And essentially, we're using the basal bone. We're using essentially an any ridge implant into that bit of basal bone. But it's with this long neck, and it's two parts, but it's one piece implant. There's no connection there. It's all one piece. There's no micro movements that's going to happen further down or anything like that. There's two parts to a single piece implant. So our connection is kept well away from the bone. So that was the plan, and that was the final result. Okay, I will go through it. I haven't jumped everything. I will go through it. So what I did for her is I put some pterygoid implants in. Okay, not Megagen, but Megagen have got pterygoid implants that are coming out very, very soon. So I can't wait for those. But to avoid sinus lifts, avoid huge distal cantilevers, there's some good bone in the pterygoid area, so I put some pterygoid implants in there. On the patient's left premolar, the transverse implant on the left side, this is where we had teeth. So obviously we had more bone. So I didn't need to put an Ari. This is a blue diamond implant. I think it's a 4.4 by 13. Very good stability on that. Plenty of bone to play with. And, I did do some alveoplasty, did have to hide the transition line for her. So we did get a little bit closer to the sinuses as well. But despite that, anteriorly, we've got 8mm polished collars on those two anterior Ari implants, plus 7mm in the bone. And the transverse one on the right, 7mm in the bone, and 10mm polished collar. So quite a long implant. It's not something that we're sort of used to using, and even looking at it looks a bit funny, looks a bit alien. But it helped us produce a very stable implant placement, and immediately loaded at the time. I didn't load the pterygoids because actually if I go back, you can see the implant on the right, the pterygoid implant on the right, there's no healing cap on there. Her wisdom tooth had over erupted so much, I had to trim it down and put one on later. But we couldn't connect it up to it. Her lowers are going to go, as I say, she was sedated. Otherwise I would have taken out the lower wisdom tooth at the time, but consent and all that stuff that we have to contend with. So we'll do that when we do the lowers. Okay, so raised the flap, took the teeth out, and had to do some bone leveling, as I say. So we measure from our photos, from our smile line, trying to hide the smile line, the transition line when she's smiling, and still very thin ridge. And I've actually prepared, you can probably just about see the pilot osteotomies. Do you know what? I'll just pop on the laser pointer, or the fake laser pointer. I always tend to do my osteotomies, and the other one is just here, before doing my bone leveling, because I've got my reference points as to where I am. I can check from my CT scan, what little dip in the bone there is, and where my drill is going to go in relation to that. So I do my pilot, then I level the bone, then I start to work on developing those osteotomies. So first couple of drills anteriorly here. Now this is a mirror view. You can see this is what we have on the, let's say, the right of your screen. This is kind of where we want to go. So we want to place our implants this way against the bone. We don't want it to come too palatal. Prosthesis will be quite thick and there'll be a big space. So on the other one here, this is not ideal. Now, I'd love to lie to you and say I did this for the purpose of the photograph and for teaching, but it's quite tricky to get it in. Now, the great thing about the kit is that it comes with a Lindemann burr, but it doesn't come with one Lindemann burr, it comes with 3. So every time you're increasing the diameter of your osteotomy, you can use the Lindemann burr. Lindemann burr is a side cutting kind of burr. So we can use a Lindemann burr and lean it in against that bone and bring things, so moving the burr from here, and we can sort of move it a bit more buccal and start to remove some of the bone. There are also other profiler burrs in there as well, and it's kind of sequenced as you go, so you don't have to do it all at the end, which would probably be difficult to get the rest of your implant in the right place. You do it gradually as you go, which is great. It's fantastic. They've really thought about the kit and how we're going to get to place the implant in the perfect position. The other thing with this is it's very similar to immediate implants. Like if you're proficient with immediate implants, If for example, you've got a socket, upper central socket, generally speaking, we go more into the palatal and bone with our, I'm talking non-guided here, right? You go into the palatal bone, and then you start to straighten up and bring your osteotomy into a more favorable restorative position. Same thing with this, but you're going in a bit more this way and then coming out buccally, if that makes sense. And then, with the tools that you have, you get to place the implant into the correct position. So you can see here, there's a lot more profiling done around here, a little bit here, and obviously with the transverse one on the patient's, I think this is a mirror image on the right side. This blue diamond was placed. I mean, you can see this where we have teeth, we have bone. So blue diamond implant placed, no issues there. All right, so this is placing the Ari implants now. You can see this is now hugging the bone a lot better. This is hugging the bone better here as well. This is okay here. The gold caps are carriers, just literally to be able to carry it out of the pack, put it into the patient now. Well, it also helps you when you're doing multiple implants to kind of see where you are with it all. Bear in mind this notch that we have here. That's kind of where you want to place it. That's where your bone level should be, roughly. Because in the kind of the lower part of that carrier, that houses the hex. It houses the external hex. So don't think your implant starts at the base of that carrier. There's a external hex component buried inside that carrier. So that's why we want to take it basically to the notch. And then we take the carriers off, and we can see our implants in the right place here. Okay, so AXA abutments. So basically, these are the new and improved multi-unit abutments. Okay, that's kind of how you have to look at them. Multi-unit abutments, are great. They've been around for a long time. The best thing still about them is the compatibility with lots of different things in terms of photogrammetry, in terms of lab, in terms of cylinders. Everything fits pretty much in all the multi-units from any brand. However, times have moved on. Things can be improved, and they have been improved. And yeah, one of the things that we can see here, these are not actually the multi-unit abutments on here. These are the kind of the angle. You're checking the angle with these things. I can't remember what the name was. So you put these things on. The green ones here at the back are 30-degree angles. They have straight, and they have 12 and 20. Okay, so the yellow is 12 and the red is 20, all the other way around. But essentially, you put these on, you can check what angle you're going to be restoring at. So you can see the restorative screw coming through here, 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 and here. Now, this is not an ideal place for a restorative screw. The great thing about this, you can see it comes with a wrench adapter, because this is an implant driver as well. So you can place your wrench on that and turn the whole implant and get your restorative screw into the correct position, or obviously move it. But if you go in between the two hex positions, it's a very, very, very clever tool that allows you to rotate the implant to get the restorative screw into the exact position you want. And then you take these bits off, you put the actual AXA abutments in. So these are the multi-unit AXAs. They're called AXAs. I refer to them as multi-unit AXAs. So these are the ones, the gold ones here are for the Ari. So many names to remember, right? They all kind of sound similar. So the Ari implants, AXA multi-unit abutments, and then this is the AXA as well, but for the blue diamond implant. So the platform is all then the same. So the whatever you put on top of this, you can put on top of this. They're all the same at this point. All right, hopefully that makes sense. So these are all in place. And I didn't actually do any contourization because the soft tissue was pretty thick, and I felt it was sufficient. We've got good buccal bone on top of our implants as well. There's no fenestration or dehiscence in that area. So I just closed everything up. These are scannable healing caps, the white ones. Okay, these are the ones that go onto AXA, which is great if you're doing a digital workflow. I personally prefer to do things analog at this stage for the temporary, and then later for the final, I would do it digitally. But if you wanted to do things digitally, you put these on, you scan them, take a photogrammetry reading or however else you do it, and then you get your temporary milled or 3D printed. In my case, I have a CDT that I work with, Adam from Eden Dental Lab. So he came in, he's made some teeth, and he does a pickup of the soft tissue, and we protect with a rubber dam, temporary cylinders. Okay, maybe it's an old-fashioned way, but it's a quick way. And some acrylic goes in. We load the pre-made teeth into the mouth, get the patient to bite down, get the occlusion, near enough right, and let it set. He takes that next door, he cleans everything up, fills the gaps, polishes. It is cleansable. I like to leave it quite flat so it can push and compress the soft tissue a little bit, but it's definitely cleansable, and there's no undercuts there. That's all been removed. Yeah, we didn't load the pterygoids because of that lower wisdom tooth, if you remember. So we just loaded the anterior ones, but for the final, obviously we'll have them all connected up. Take the load off. It's quite the implants are quite anterior, coming through at the fore area. Okay, so this is it in the mouth. Yes, teeth can be a bit longer, look a bit nicer, but for a temporary, I think it's a good result thinking about the amount of bone that she had. Okay, 2 weeks post-op. This is as much review as you're going to get from me, I'm afraid. So we've only just had them launched in the UK, but this is how it was all healing at that point. And yeah, hopefully next time I'll show you the definitive result as well. Right, so AXA, this was touched on again, but I think it's really, really amazing product. Main difference between the traditional sort of Nobel N-type MUA is the longer post. The other good thing about this, it's kind of an indexed post, so you can use these on single units. As Rokas was showing, like single unit, central lateral incisors, and you want to sort of change the angle because you need to hide the prosthetic access screw. You can put an AXA on there, and you can do a single crown on there because it is indexed, it's not going to spin around. The shelf here is much wider. So previously, we could do zirconia directly onto these, but there was problems with chipping. But over here, the kind of the collar around is wider, so it's been designed for zirconia, so we can avoid metal. Even the screw design is different. The screws are wider, the diameter of the screws is wider, so less likely to fracture. Lots of little things have improved. Even the profile here, you can see it's not as bulky, so we don't have to do so much bone profiling to get them in as well, which is always helpful. And then I mentioned this earlier, but they have different angles. Okay, so 0 and 30, which is the traditional ones that we're used to, and with the Nobel type, there was 17. I was actually at the conference, the Megagen conference in Toronto, and Paolo Mallo was speaking. And he mentioned that the 17 wasn't really kind of what he planned for. He planned for 0 and 30 and 15 because 15 was in the middle. He said, but they just made him a 17 and it just kind of stuck and they went with it. So that was, I was always wondering, why was it 17? I thought there was some kind of thought process that got into it, but it seemed like it was just a mistake. So yeah, but we're here, they've changed that to 12 and 20 because sometimes anteriorly 17 is a bit too much and 0 is not enough. It's just, you need to go somewhere in between. So 12 for those anterior cases, 20 when you need to do a little bit more, which is not far away from 17 as well. So it's nice to have a couple more options available to you. And you can use these on Ari implants, on Blue Diamond implants, Blue Diamond cuff implants. And I think they're coming out with them on the Eneridge implants pretty soon as well. So this is the tool I showed you earlier. So this goes on to your implant. So in this case, this is a Blue Diamond cuff implant, and it's gone onto. And then you put the wrench on, and then this, you can turn the wrench and move the prosthetic screw position. Okay, you'll kind of see it in this video. I don't know if it shows it very well. A bit of a shaky video. So you can move it, and that can change the position very, very slightly and get you into the right position, especially if you're doing FP1 cases, stuff like that, where it's vital to be spot on. So yeah, just a clever, essentially implant driver, but also allows you to check your angulation. And if it's not the right angle, obviously take it off, put a 20-degree on, put a 30-degree on until you're happy with the AXA that you're going to open. So this is a different case. This is a Blue Diamond cuff case that actually I did in Mexico. So I was quite fortunate enough to go to Mexico in April earlier this year to try out some of these implants. So we tried some Ari implants on patients there and some Blue Diamond cuff and all the AXAs. So this is just to show you with the AXA abutments that have gone in and then scannable healing caps. Unfortunately, I wasn't able to get another implant in on that upper left side because of very soft bone. And in this particular case, we did scan it because I didn't have my technician, and the protocol was everything's going to be digital. So we scanned, did an intraoral scan, and then photogrammetry scan. So R2 gate, R2 photogram. So Megagen has a photogrammetry, which is great. And it's great because, as I mentioned earlier, moving away from the N-type multi-unit and photogrammetry, if you already have one, or in my case, I use my lab. My lab comes to me and very kindly, this is DNH lab. They bring their photogrammetry, and for my finals, we do all our intraoral scans and get a very, very accurate positioning and pickup of our implant positions. Now with AXA, the lab doesn't have those scan bodies, it doesn't fit, and I can't really get them, but now I can. And these are the scan bodies we use in Mexico, which also I believe is compatible for the Runya's scanner, which is basically what Megagen is using, is repurposed their scanner as an R2 scanner. And hopefully we'll be selling it in the UK soon because I'm looking to get one. And it's quite a competitive price, about half the price, I think, of a Tupel, from what I've been told. So anyway, these things go in. These are the scan bodies for the photogrammetry, okay? And they fit onto the AXA. And then, you kind of just basically, it's an extraoral scanner. So you're using this camera, you're moving it side to side, and you're picking up the positions. And when they all turn green, it means that you've got all the positions accurately. I don't know how they do it, but the technicians, they take that data, take your intraoral scan data, they merge the two, they make sure the implant's in the right position, and they take the soft tissue scan data from your intraoral scan and produce you a try-in, basically a 3D printed, or in my case, I like to do a milled try-in. They're just stronger. So we do a try-in, and then the next appointment, make adjustments to that, check the occlusion, make sure everything's fine, take a new intraoral scan of the try-in in place, and then they mill out the definitive, which is great. So this is the center in Mexico, where basically had the opportunity to spend some time with Dr. Park, and it's a nice open clinic with cubicles and lots of courses happening there, and got to try out the Ari implants and the BD cuff implants for the first time. They've got a nice classroom at the top floor as well. So the reason I mention that is, as I said, with innovative implants from Megagen, there is also an innovative implant training academy, which my colleague and I run together. And we are going to Mexico actually in October for a full arch course. We're fully booked for that. So we've just released some dates for May next year. And if anyone is looking to place generally Ari implants, BD cuff implants, or to undertake full arch cases with kind of regular implants, or even some of these newer implants, and this is a perfect place to go. It's a Minek implant center, so we have everything Megagen, all the implants, all the multi-units, the access, everything else. It's all there. So if you're interested in that, let me know or speak to Alga. We're doing a training day in London, and that's probably going to be in March next year, and then 3 days in May where we're doing hands-on on patients. Each delegate will have 3 full arches to treat themselves, and they'll assist in another 3 on those 3 days. So it's going to be a very, very busy day. And as I say, our first cohort is going out in October. So we'll share some more details from that. That's our Instagram page. So if you want to follow and hear about when that's how that course has gone and any other updates related to that, that would be great. And if you're not quite sure yet, and you want to do something a bit closer to home, we are doing an Ari masterclass. Now this is actually a free masterclass. Megagen's put this on, which is great. And there'll be a bit more detail in terms of, obviously you've had an hour today. We'll have a bit more detail in terms of the lectures and things like that. We'll do hands-on models where you can actually try out these Ari implants on models, on atrophic ridge models, and just get a feel for them. So we're doing this first one in Luton on the 18th of September, which is a Friday. And it'd be lovely to have you all there. I think there's only a few places left for this. So if you are interested in this, there is a QR code for you to register, where you can register online. And if you need any more information, again, speak to myself or Alga. We'll be happy to help.